Good afternoon, everyone. I am Dr. Saurav Shishir Agrawal, consultant endocrinologist at Yatharth Group of Super Specialty Hospitals, Noida. Today, I'm going to discuss a commonly seen scenario in our diabetic and endocrine clinics. A middle aged male who is a newly diagnosed diabetes. He has come with complaints of weakness. He has some high risk features like the presence of hypertension, a chronic history of smoking, and history of myocardial infarction, which is sustained 3 months back. Another significant history is a family history which is positive for hypertension and myocardial infarction. Now, on examination, the high risk features which are there is a BMI of 30.7, blood pressure of 140 by 90 millimeters of mercury. The lab investigations revealed HbA1c of 8.4%, which is 1.5% above the baseline target HbA1c. So he's already on the maximum dose of a first line drug, which is metformin 1 gram twice a day. So now coming to the diabetes management, what we want is the comprehensive diabetes management when we are talking in 2021. So what we are basically aiming at is managing the suboptimal glycemic control, the dyslipidemia, providing him with a drug which can provide cardiovascular and renal protection, considering the BMI on the higher side, the drug which can help in weight reduction, and maybe considering the hectic lifestyle, a drug which is present in a dosing schedule which can optimize compliance with low risk of hypoglycemia. Now, I will try to cover these things one by one. So, coming first to the most important thing, which is glycemic control. Now, if we see the patient is a newly diagnosed diabetes, so it has been seen that poor HbA1c control, especially in the first year of diagnosis, has poor long-term cardiovascular outcomes, which has been seen in longitudinal studies known as legacy effect. So the patient is on already maximum dose of metformin 1 gram. So we want to quickly lower the glucose levels to the target of optimal target HbA1c of less than 7%. So the patient already having a baseline HbA1c more than 1.5%, probably it will be difficult to do this with a monotherapy. So the ideal thing which should be done is to put him on a combination therapy. So we would like to choose two drugs which have complementary mechanism of action. The best possible combination which we have now in these stages is combination of SGLT2 inhibitor with a DPP4 inhibitor. So a combination of SGLT2 inhibitor, these two provide a complementary mechanism of action. While SGLT2 inhibitor has a potential of increasing glucose production, the linagliptin decreases the increase in endogenous glucose production. And the combination when used can decrease HbA1c to the tune of 1.8 to 1.9% from the baseline. Now coming to the second outcome, which is to provide him with a drug which can provide him good cardiovascular benefits, especially considering the history of MI at a young age, or maybe a history of premature atherosclerotic cardiovascular disease. So now if we see cardiovascular disease, they are the major cause of premature death in type 2 diabetics. They occur around 12 to 15 years earlier, and diabetes itself confers twice the risk of having a cardiovascular event than the patients who are not having diabetes. Especially considering the Indian scenario, like this patients commonly have coexisting hypertension, obesity, dyslipidemia, and a strong family history. So we want a drug which decreases the risk of cardiovascular death, decreases heart failure risk, decreases risk of stroke, hospitalization. So if we see the SGLT2 inhibitors, especially empagliflozin, it has shown good cardiovascular benefits in the dedicated CVOT trials like EMPA-REG, in which there was a decrease of 14% in 3-point MACE and decrease of 38% in cardiovascular death. There are various postulated mechanisms of benefit like osmotic diuresis and natriuresis, decreasing arterial stiffness, decreasing uric acid level, plasma volume, decreasing oxidative stress. So by changing the myocardial energetics, SGLT2 inhibitors, especially empagliflozin, has a good track record of decreasing the cardiovascular death and cardiovascular events. Further, the addition of linagliptin that provides a synergistic benefit because in trials like Carmelina and Carolina, cardiovascular, which were cardiovascular trials, linagliptin has shown good cardiovascular safety. Coming to the third target, which is providing the drug with a proven renal benefits, considering the GFR being slightly on the lower side with a urine albumin excretion more than 30 milligram per gram, suggestive of already present nephropathy. Now, if we see the diabetic nephropathy, so basically the drugs like SGLT2 inhibitors, the altered tumoroglomerular feedback which is present in early stages of diabetes, that is restored by the SGLT2 inhibitors, and they have shown to decrease the level of albuminuria, and they result in persistence of stabilization of eGFR. Further, drug like linagliptin, which has shown decreased albuminuria production by 14% in Carmelina trial and decreased risk of new onset or worsening nephropathy. One major benefit of using this fixed drug combination is that unlike another DPP4 inhibitors, linagliptin does not require any dose change in renal compromised patients. Coming to our fourth target in this patient, a BMI of 30.2, obesity especially rampant in the Indian population. So the drugs which can provide us weight reduction are very limited if you see the diabetic scenario. After metformin, the drug which is most effective is empagliflozin, which can be combined with a drug like linagliptin, which is weight neutral. Other benefits which can be provided by this combination is decreasing the level of uric acid by empagliflozin. And if we see the adverse effect risk is very low with this drug combination, though minor, but they can be present for every drug class. So the last thing, which is not much theoretically, but yes, practically very important, is optimizing the compliance of the patient. If you're putting the patient on maybe 2 or 3 drugs at different time intervals, sometimes with a hectic lifestyle, the patient is not able to cope up with those, and they come to us in OPD telling that probably the number of the drugs which you are writing is probably too much. So the ease of taking the combination once daily further adds to better compliance, which has shown long-term good effects. So the combination of these two drugs can result in robust HbA1c reduction, proven cardiovascular and renal benefits, weight reduction, low hypoglycemia risk, and with the convenience of once daily dose, better compliance and long-term outcomes. So probably the message which I want to send is the management of diabetes has progressively evolved from what you used to do 10 years back. Now we have newer class of drugs which have good safety records, good cardiovascular and renal benefits, and a good combination which improves the compliance. So thank you for listening to me. That is it from my side.